Hi, I'm Carrie Mulhern, Chief Marketing Officer at Brava Diagnostics. Brava is developing a low-cost, high-sensitivity troponin test that will deliver lab-quality results in 15 minutes at the point of care. This presentation reviews data from 2 large clinical studies that established clinical utility for high-sensitivity troponin, lending further support to the market need. These trials add to the evidence regarding how high-sensitivity troponin can be used to optimize chest pain care pathways for diagnostic ruling as well as for safe discharge. Discharging low-risk patients for outpatient management could ease overcrowding, reduce excess admissions, and significantly reduce costs to the healthcare system. Troponin is a well-established biomarker for myocardial injury. For a large infarct, troponin is measurable in 4 to 8 hours post-infarct depending on the sensitivity of the assay used. For a smaller injury, the peak concentration is lower and troponin is in circulation for a few days. The U.S. and European guidelines establish the 99th percentile of the reference range as the diagnostic threshold for myocardial infarction. If you look at the concentration curve in a time frame relevant to an emergency department visit, you can see that the high sensitivity assay could give the doctor a positive test result 4 to 5 hours earlier than a contemporary assay. That shorter troponin blind period has an impact on efficiency of treatment decisions or safe discharge. Let's take a closer look at the data from the HiSTEACS study that supports safe discharge. The objective was to identify a troponin concentration that could maximize the number of low-risk chest pain patients who could be discharged safely. They set a target negative predictive value at 99.5% to minimize the number of patients discharged inappropriately. From 6,304 patients, they calculated the NPV at various troponin concentrations and determined that less than 5 nanograms per liter would meet the NPV safety criteria and identify 2/3 of the low-risk patients. This is the early rule-out pathway for EKG-negative patients with chest pain that they developed from the data. Patients with a high-sensitivity troponin of less than 5 nanograms per liter were classified as low risk and were managed on an outpatient basis. Per guidelines, patients greater than the sex-specific 99th percentile were classified as high risk and admitted. Patients with troponin greater than 5 nanograms per liter and less than the 99th percentile were retested in 3 hours. Patients with changes less than 3 nanograms per liter were discharged. Patients with greater than 3 nanograms per liter were admitted. The HiSTORIC trial was conducted to test the high-stakes early rule-out pathway prospectively. 7 hospitals across Scotland participated. The validation phase ran for 6 to 9 months. Then the sites were randomized stepwise to implementing the early rule-out pathway, which ran for another 6 to 9 months. They looked at outcomes at 1 month and 1 year. 31,492 consecutive patients were enrolled overall. Ultimately, 14,700 patients were randomized to the standard of care cohort, and 16,792 were assigned to the early rule-out cohort. This graph shows the event rates for the full cohorts. The standard of care group had a 2.7% event rate compared to a 1.8% event rate in the early rule-out group at the 1-year time point. Faster rule-out did not increase adverse events. Looking at the primary efficacy endpoints in the calendar-matched standard of care group versus the early rule-out group, they found a 35% reduction in the mean length of stay. There was a 57% increase in the proportion of patients discharged from the emergency department. The HiSTORIC investigators prospectively studied safety and efficacy of the high-stakes early rule-out pathway in over 31,000 patients. They concluded that using separate troponin concentration thresholds for diagnosis and risk stratification was more effective than the standard of care. Implementation reduced overall length of stay by 3.3 hours and increased the proportion of patients discharged from the emergency department by 57%. There was no increase in adverse events at 1 year. The early rule-out pathway is indeed safe and effective. The implication is that emergency department crowding could be reduced and there could be a significant cost savings to the healthcare system. Finally, Brava may be able to accelerate rule-out decisions by an additional 30 to 45 minutes with our point-of-care test compared to the central lab assay that was used in this study. Thanks for listening. Please contact us to learn more about Brava.